Very good. Now we're going to dive into some presentations. We will hear from Dr. Karen Randall, who edified the board at our retreat this summer. We wanted to have a more up-to-date policy consideration from the last policy statement that the IMA made, which was in 2012. So we reached out to some experts and had several internal conversations, and then had presentations at our board retreat. We were very pleased with the folks that we had to speak with us electronically, to include Dr. Karen Randall and Dr. Dan Zuckerman. The conversations and processes have resulted in 2 resolutions that will be deliberated later today, resolutions 107 and 108. First, we will hear from Dr. Karen Randall, who is an emergency room physician in Pueblo, Colorado, and has, by her own direction and motivation, become certified in cannabis science and medicine through the University of Vermont. Dr. Randall is residency trained in pediatrics, family medicine, and emergency medicine. And she worked first in Detroit for 18 years as teaching faculty, and then she moved to Pueblo. She has published many articles and chapters with regards to emergent presentation of cannabis harms, and served as on the Substance Abuse and Mental Health Services Administration Technical Expert Panel on Cannabis. After Dr. Randall's presentation, we'll also play a video that was recorded during the board's retreat by Dr. Dan Zuckerman, who is the director at St. Luke's Cancer Institute in Boise. We asked him to join us to present on oncologic aspects of this issue. He will not be able to join us live today. He's doing the team soccer effort with his family, and so he couldn't be with us today. But we've asked him for his permission to broadcast what he presented in the summer, and he agreed. So we will see that presentation, which is very edifying. So after these presentations, there will be an opportunity to ask questions, and I hope for a vigorous discussion. So now we'll turn it over to Dr. Randall.
Hi, can you hear me? And I hope that Sarah can screen share my slide deck. Give her a minute to get that up. Thanks, Sarah. So my topic today is to discuss cannabis as a medicine, and is it really ready for prime time? By way of disclosures, this slide is a couple months old. I have accepted like a intermittent, I'm on the scientific board now of Fleo Pharmacy, and they're developing an antidote, or working on an antidote to cannabis addiction medicine. It is in the phase 1 FDA trials, and I have been a scientific advisor on their board. So that's the only disclosure I have. I'm not signed as a contract with them, and I'm not making money from them. I don't have any other shares in product sales, and I don't really actually get much money. If I get my expenses covered for talking about this, I'm super happy. So I think what we really need to talk about before we talk about cannabis and the harms is what is cannabis and what are we being presented? And it's really hard to combine this in 20 minutes. It took me 10 years to become knowledgeable. But so let's go to the next slide. And if we look at the basics, all cannabis products come from the plant labeled cannabis sativa, and then we have separate species. And you can see the 3 different species here. It's indica, ruderalis, and we have sativa. Next slide, please. So when we look at the basics of the plant, there are hundreds of chemical compounds, and the most commonly known are THC, CBD, CBN, but there's also terpenes and other chemicals. There's probably about 400 or 500 active chemicals, and we don't actually really know what all of them do. But basically, THC is a neuromodulatory system in our endocannabinoid system. And unfortunately, our system was named endocannabinoid because the THC molecule fit on that, but it's probably a bad name for this. I mean, we have opiate receptors, but we didn't name them heroin system. So it's probably kind of a bad name for it, but we do have an endocannabinoid system. It's an anandamide system. We have receptors scattered throughout our body. We do have them throughout our brain, but in the case of cannabis, the industry is very forthcoming with saying that it doesn't cause death. And it doesn't cause death in the fashion that like heroin or opiates do, because we don't have a lot of receptors in the brainstem. So if you look on YouTube, you can see I took a 31,000 milligram dab challenge and I didn't die. You can see videos. And the reason is because we don't have them in our brainstem, so we don't stop breathing if there's an excessive intake of THC. But there are other drawbacks like seizures, coma, injuries, aspiration, that kind of stuff. So it isn't completely without harm. Next slide, please. So when we look at THC, which is the active component, which is, it's hard to do a full lecture in 20 minutes about THC and CBD. So we're going to focus mostly on THC with some topics on CBD. THC is either indica or sativa or a mixture of the both. And it's easy to remember. Sativa is more of the upper, I feel, active, I feel creative. And indica, you can remember because it's indicouch and it's more of the sedative. People would take it at nighttime to help them sleep, that kind of thing. Next slide. So if we look at the history, and this is where the difference comes in for medicine, and this is where the harms come in. In the 1990s and before, the THC content of a joint was usually about 5% if you got a good one, and it had about 1 to 3 milligrams of THC. And typically, if you look at the history and you look at the social patterns, it was smoked and shared. Sometimes it was baked and cooked, but also shared. But typically it was shared. So it was 1 to 3 milligrams, and you were sharing this with your friends in a social activity. Next slide, please. When we look at our current preparations, smoked means flower is smoked. Flower in Colorado is currently 20% THC. So there's a marked increase there. And then we talk about concentrates. So what you need to know, and what I find here too in Colorado all the time, is that people practicing medicine don't have any idea of what their patient is saying when he smoked a dab or a bowl, or he did 2,000 milligrams of THC. We don't have a concept. And that's even here where we see cannabis issues every day. So when we look at the current preparations in Colorado, we have smoked, we have concentrates, and concentrates are an extract. It's a THC extract made of the plant, and it's usually made with butane or propane as the solvent to create the extract. This was the home labs, the HBO labs that people used to do that would blow up. They would take a turkey baster, stuff the plant in it, use propane or butane as the solvent, make an extract, and dry it. The problem is that as you concentrate THC into an extract, you also concentrate the contaminants like heavy metals, poisons, fungus, bacteria, and fertilizers. And the THC, or the cannabis sativa plant itself, is actually a soil scrubber. So it will pick up everything in the soil. And I've heard, but I haven't verified, that they're using cannabis sativa to clean the radiation from Chernobyl in the soil. So everything that gets concentrated in the final extract, which is known as dab wax or shatter. And I'll show you that in a minute. We also have preparations in food, candy, gummies, cookies, etc. And I'll show you a little bit of that because it's amazing what we can have, what preparations we have it in. So this is what a THC concentrate looks like. It's called dab wax or shatter. Shatter looks like broken peanut brittle. You can see that on the right-hand side. Concentrates, you can have a tincture, which will come in a dropper in a bottle. You can have wax, which is named wax because it looks like, if you actually look at it, it's yellow and it looks like earwax. Most of all of these preparations, with the exception of a tincture, which you can put under your tongue and absorb in your mucous membranes, these are all meant to be smoked. Sometimes you can use the extracts to cook in as well. Next slide, please. So here's some of the preparations that we're actually seeing on the market. Most people don't know about it, but you can get a THC infused tampon, a THC infused toothpick, you can get chapstick, you can get condoms, you can get toothpaste, you can have whatever you want, you can get THC in. So if we're going to look at this as a medication, do we really need to medicate condoms per se? So, I mean, I think we say it's a medicine, but if it's really want to be a medicine, then we should treat it like a medicine. And most of these preparations aren't necessary. I don't know that we need THC infused toothpicks, but we have them here on the market. They're sold both as medicine and as recreational. Next slide, please. When we look at the candy and the food preparations, this is a big issue here in Colorado because many of these preparations look really appealing to children. And if you look at some of these products across the slide, the soda pops, the chocolate bar, you can get it in coffee, a Keurig coffee, you can have it in a tincture, you can have it in candy and gummies, you can get candy, all kinds of things. So what happens is they'll take the THC extract and they'll either bake it in or spray it on a product. These products in Colorado have formerly had super high concentrations of THC. And so like probably a year ago, I had 2 kids who bought a medicated candy, was a Nerds rope off the internet from Snapchat, and it contained 500 milligrams of THC in it. So when you look back at the original concentration of THC in a joint, it was 2 to 3 milligrams, and they bought a candy that had 500 milligrams of THC in the candy. And of course, they each ate half and ended up in our emergency department. Let's go to the next slide, please. So when we look at medical cannabis, and the reason I got my certificate in cannabis, because I was speaking out, but people would say, I don't actually really know about it. So I went back to get the certificate, and I learned quite a bit. So my feeling about medical cannabis is, first, no medicine should be smoked or vaped, because we know that there's vaping issues. Right before COVID hit, we had the vaping lung crisis, or EVALE, e-cigarette vaping lung disease, which was probably about 80% or 85% associated with THC, and that was the e-cigarette associated lung injury. It is similar to popcorn lung, and it causes permanent damage. There have been case reports of a patient who a couple patients who needed lung transplant after having vaping injury. There's also a case report of a patient who was on chemotherapy who died of an atypical fungal infection, because if you look at this product itself, it's grown in a very high, very humid environment because they are forcing the life cycle to happen faster. So they're very prone to getting fungus, and they've had all kinds of funguses reported. One case report shows aspergillosis, but there have been other funguses reported. And if the patient is smoking this, he's inhaling it directly into his lungs, making him a problem. Again, when we talked about the plant being a soil scrubber, we are seeing concentration of heavy metals in the final product itself. And what we're seeing is an increase in cadmium, lead, chromium, arsenic, and mercury also have been seen. So, and those are difficult because we don't really excrete those on our own. And right now, I just saw a report on TV about lead poisoning in children across America. And this is one of the issues that we face. So let's go to the next slide, please. Back to edibles. Edible is an interesting creature itself because it undergoes something called first pass metabolism. It's metabolized in the liver, and it goes through the P450 system. And anything else that we metabolize in our liver in the P450 system will compete and be altered when you're doing cannabis. And people often are doing a lot of cannabis, so their system is busy. And some of these medications are seizure medications, HIV medications, warfarin, some of the immunosuppressive medicines for people who've had transplants are also in the system. And so what we see is there have been multiple case reports about bleeding with people on warfarin who are also using edibles. And there's also like accidental overdosing on edibles. We've seen multiple case reports of children who've had accidental overdose. The youngest patient I've seen here in Colorado was 11 months old, and he reportedly ate some of his parents' cannabis, and he came in with status seizures. Let's go to the next slide. So these are what the edibles look like here in Colorado. We just passed some legislative rules to not have edibles be so appealing to children, because if you look, and you have to look closely, look at the bottom right-hand corner, Starburst gummies and Skittles. If you're a child, and you may not recognize the fact that there are very, very tiny cannabis leaves printed on this. If it's out of the package, there's no way for a child to know. We've had a marked increase in calls to poison control with regards to accidental, and sometimes in the older kids and teens, intentional ingestions. Next slide, please. This is the package of the Nerds rope that is on the market here. Kids, what happens is a person will sell it on Snapchat, so that the call is out for just a couple minutes and then that text disappears. Kids know where to go buy it, and this is one of the products that they're getting. It's Nerds rope, but if you look at the concentration, it's 400 milligrams. So back to the first joint, which was 1 to 3 milligrams, we're talking about 400 milligrams in a 12-year-old or a 14-year-old. That's a substantial increase, and it does cause substantial problems. The good news is they don't have respiratory failure. The bad news is they totally come altered. In fact, we had a 77-year-old grandmother just a couple days ago who was doing edibles and came in acutely altered and got intubated because she was acutely altered and we thought she was having a stroke. Next slide, please. This is the Nerds rope package that I took off, one of the kids gave me. So it's out there and it's our community, and literally there is very little way to protect our kids because it's out there, and it doesn't matter about socioeconomic status. Your kids are going to get exposed to this, and it's very difficult to control once it's out in the environment. Next slide, please. So I took the course mainly because I'm like, well, what is dosing? Like, I've asked my patients, what is dosing? I've only seen one person who admitted to writing for cannabis medical certificates, and they couldn't tell me. And so currently in Colorado, what happens is you see a physician, you get your certificate, and you send the patient to a dispensary where they get told what they should take and the dose by a bud tender who literally has, most of the time, no medical training whatsoever. So this is the only dosing chart I found, and it is by cannabis industry. It's by leaf fly, and 1 to 2.5 milligrams. And you can see the dosing schedule there, 50 to 100 milligrams. So they're talking about significant side effects. However, here frequently my patients will tell me they take 2,000 to 5,000 milligrams. And what we find is that patients will self-diagnose and self-treat all kinds of disorders based on it being a medicine and being advertised as healthful. Next chart, next slide, please. So anyway, I don't know of a dosing. I was told by one medical marijuana dispensary owner that they start patients at 5 milligrams, titrate rapidly to 100 milligrams, and tell them, oh, we'll have you up there in months. Again, my patients tell me they take 2,000 to 5,000 milligrams a day. The fact that these doses can escalate to that amount and have people up and walking, which they frequently are, it speaks to tolerance and also speaks to addiction. During a recent Senate testimony in Colorado, one of the cannabis prescribers for certificates told me he tells his patients to go to a drop-down menu and pick their medicines online and order the quantity they want. And I can't imagine as a physician doing that with any other medication. And you can only imagine what would happen with the opiates if we told our patients, go to the drop-down menu, pick what you want, order the quantity you want, and take it as you see fit. So there's a lot of work to be done. If we're really going to treat this like a medicine, it has to be regulated like a medicine. We know there are very potent side effects, and we'll talk about those coming up next. So I think it needs to be treated like the psychoactive medication that it is. Next slide. Some of the side effects that we see CHS, cannabinoid hyperemesis. 10, 15 years ago when I was teaching residents, it was a case report. And now we see it probably 2 to 3 times a day, every shift. Yesterday here working, we saw a 16-year-old girl who'd had probably 30 visits to the ER in the previous 6 months, multiple admissions for cannabis hyperemesis. And because they get withdrawal symptoms, they are having difficulty stopping. We had a 19-year-old kid in hospice because he was starving to death because he had CHS so badly but couldn't stop using. The next big complication or side effect that we see is acute psychosis. And I was lucky enough to serve on the SAMHSA panel with Dr. D'Souza, who's in Connecticut. And in the 90s, he did studies that he gave 5 milligrams of THC to people who were naive or not used to it. And he could, with just 5 milligrams, induce psychosis and hallucinations that were similar to schizophrenia. And that was just with 5 milligrams. And now, again, we're talking about dosing ranges of 2 to 5,000 milligrams, or even if you go on the low side, 100 milligrams. So we also see acute delirium. The 77-year-old lady who was admitted to our emergency department a couple days ago had acute delirium from ingesting edibles. That information wasn't forthcoming. She presented as acute stroke and was wildly combative and ended up being intubated to get behavioral control so we could get a CT scan on her. Turns out later the family admitted to grandma doing a lot of edibles. And the issue with edibles is that as undergoes first pass metabolism. So what happens is people don't wait long enough to let the edible digest, so they don't get any symptoms or side effects from it. And so they ingest more, and then they ingest more. Someone likened it to being on a roller coaster. You know the ride's going to start, but you're not exactly sure when. But the problem with edibles is once the ride starts, you're on it till the end. So they don't come out. We've seen a lot of accidental ingestions by kids and other people, again, elderly people. We've seen pulmonary side effects such as a valley pneumonia, atypical fungal infections. There are more and more reports about cardiovascular side effects such as hypertension, stroke, and acute coronary syndrome that we've seen, usually typically following the smoking of cannabis within an hour or so. And this is in young people, so this is of concern. With the topical presentations, I have seen some of the worst dermatitis I've ever seen in my career with topical preparations. Again, there are, I think, a few people in the state of Colorado who are in the medical enforcement or marijuana enforcement division, MED, but it's very difficult for them to supervise or regulate all the products. So there are a lot of contaminants. And the truth is that the industry continues to represent this as natural, beneficial, harmless, safe. There are, if you look up online, you can see hundreds of recommendations for treatments. And for some reason, the industry is being allowed to do this. Let's go to the next slide, please. So we do have some current preparations medically. We have Marinol, which is synthetic delta-9 THC preparation. We have Savatex, which is THC and cannabidiol. It's an oral mucosal spray. It's not currently recommended in the US. Recently, Charlotte's Web, which is the preparation for pediatric seizure disorder. And this is really recommended only for 2 pediatric seizure disorders that are exceptionally rare in the US. And there's probably less than 200,000 kids with these disorders. But a lot of people will buy this preparation and treat their kids. The FDA declined it as a medicine and also declined it as an herbal supplement, stating there were too many issues with it. And that just happened within the last month. Next slide, please. So there's so much to learn about cannabis, and there's so many issues. It truly may be a medication that we can use because we see that the particles, some of the chemicals will cross the blood-brain barrier. Some of them act as an anti-inflammatory. So there is potential for help, like with Alzheimer's or other intracranial issues, but we're not there yet. We are not there yet. And we cannot recommend that our patients with Alzheimer's go on medications. Just a quick side story, don't want to take up too much time, but one of the outreach nurses for southeastern Colorado said, oh yeah, I just recommend that my patient's family, for the people with Alzheimer's, go to the dispensary and get marijuana for their loved one. And I said, well, I don't have any idea what you would recommend. So what do you recommend? She goes, oh, I don't know. I just tell them to go there. And I said, well, when you send them, do you send them with a list of medications? So like we do, we can check for interactions, make sure there's no drug interactions. I said, so do you send them with a list of medications so that the bud tender can review them and make sure that there's no issue with interactions? She said, no, I don't. And I said, so when you send them there, do you give them guidance on what product? And she said, no. And so basically my interpretation of that conversation is that you're turning the care of a vulnerable patient over to a bud tender. And that's how I feel about this currently. I think ultimately with more research and more defined or refined products, there may be benefits. But at this point, I think that we have to be super careful with recommending that our patients get these. And if you look at each society, the Ophthalmologic Society does not recommend it for glaucoma because it's fast on, fast off, and they would have to use THC 6 to 8 times a day. So it's not recommended. They actually think it might be worse. The American Neurologic Society does not recommend it as a first-line treatment for pediatric seizures. It is recommended as a 4th or 5th line. So if you look at the individual medical societies, they really aren't recommending it. I don't recommend it. They're often contaminated with bacteria, heavy metals, pesticides, and these will have long-term complications as well. And so the bottom line is it's not ready to be a medication. We are the guardians of our patients. We have to make sure that they get the best healthcare possible. And right now, what we see in Colorado is day after day after day complications of high use of a product that is not ready to be considered a medication. And that's all I have to say. I'm available for questions after.
Thank you, Dr. Randall.
You're welcome.
Very, very good presentation and very edifying. We really appreciate it.
Yeah, no.
We're going to move on with Dr. Zuckerman's presentation, and then we'll wrap around with questions after that.
Yeah, happy to help. I'll be here.
Pleased to have Dr. Zuckerman, Dan Zuckerman, MD. He's the director of the St. Luke's Cancer Institute in Boise. It's a very complicated issue, and there are many perspectives, and we've invited him on board to comment on oncologic aspects of medical marijuana.
Yeah, thank you so much. Can you hear me all right?
You bet.
Yeah.
Okay. No, thank you. And thanks. I appreciate you letting me listen to Dr. Randall. And obviously, I think it's worth pointing out that my perspective is different, but it's from the context of where I practice as an oncologist. And so want to be clear that I am comfortable, speaking for myself and for my colleagues at St. Luke's Cancer Institute, and also for the Idaho Society of Clinical Oncology, which is our state society. ASCO, the American Society of Clinical Oncology, has state affiliates in every state, and am the immediate past president of that, and have reviewed it with our board, our ISCO board, where they've given me permission to speak on their behalf. I do need to state very clearly that even though I'm employed by St. Luke's, I'm not really allowed to speak on behalf of St. Luke's. So I'm sharing my personal and professional opinion. I think I did set up some slides, but a little more rudimentary, and I'll just share basically the fact that I'm not an expert in medical marijuana, but I am an expert in taking care of patients with cancer, and we'll say that I've arrived at my opinion, which I shared with the legislature, frankly, in support of medical marijuana for select medical uses, particularly because I specialize in cancer care, and from our context and perspective, frankly, just think that the benefits for that population do outweigh the risks, but it's a special population. So I don't know if I have slides that are up or we want to walk through. I sent them to somebody, but I can't remember. So I don't know if those are available.
Sarah or Jamie, can you at least respond to him? Oh, there we go.
Sorry. Texting us about something.
Yeah, and if I can do it without him, but I really just have a few slides, really just to present to you the data that I'm aware of. So the scientific aspect, and then really sort of opinion aspect, both the opinion, public opinion, patient opinion, physician opinion. And frankly, we'll just leave it open for questions after that. So, one thing that I had reviewed and trying to prepare for the legislature was just really the fact that there aren't a lot of great data. I think Dr. Randall had made note of that. And you can just go to the first, just go to my first slide. Really just to show you the data I was looking at. And so with the dearth of data, this was the most comprehensive thing I really could find, was really from the National Academies of Science, what used to be science, but now science, engineering, and medicine, because it's non-governmental, it's bipartisan, and a series of physicians put this together. And I'm really just going to show you what I've seen. And if we can just go to the next slide in terms of the sort of results of this. And so if we stay there, really, it really tried to be a comprehensive look, I think in 2017, at the use of cannabis in a whole variety of different disorders. I'm only an expert in cancer and pain that's related to cancer. So it's really that first two that I'm really just putting these slides to show you the conclusions of the National Academy of Science, Engineering, and Medicine. If we go to the next slide, and its animation. And just the first conclusion is that there is enough evidence that cannabis can be effective for treatment of chronic pain in adults. And for my purposes, that's mostly cancer-related pain. That's important because pain is a huge feature in patients with advanced cancer, particularly at the end of life. And I'll just make the statement that we, have heard a lot about the negative effects of cannabis, and I wouldn't refute any of those. I just think in the context of oncologists, we prescribe more opiates than anybody in the state. And I think all of you who are part of the IMA can actually freely look up from the Idaho State Board of Pharmacy. Our provider, we all get a monthly provider printout of the number of opiates and benzos we put out. And these are, legal, FDA approved, well-studied. But for those of us who use a lot of them, they're awful, awful drugs. I mean, they do help take care of pain, but the side effects profile, I'm going to argue, are in comparison far worse than the side effects, which do exist from medical marijuana. And that those do actually include respiratory depression and death. And so again, I'm not an expert in marijuana, but I do know that for the last decade, last few years, there's close to 50,000 opioid related deaths. And we do know some of those come from diversion of legally prescribed opiates, in addition to the effects that people are having from opiates. So I'll go to the next conclusion. If you could just hit forward. So I will say, just as a cancer physician, that we don't propose to do this because we think cannabis treats cancer. That's a common question from patients, and there is no evidence to really support or refute. It's just so poorly studied. But I will tell you that I and all the oncologists in the state and almost all nationally do not purport that cannabis can help actually treat cancer. And the data don't bear that out. If we can go to the next one. So this is the second place within oncology where we find that cannabinoids can be effective as antiemetics. And so that is proven, that's known. And the data are there for that. And that's also a vexing problem in oncology. Now, admittedly, we have a lot of FDA approved, very well studied antiemetics, including ones you're all very familiar with, like ondansetron, perhaps some that you're not as familiar with, neurokinase NK1 inhibitors that are used almost exclusively in oncology, things like prochlorperazine, things like dexamethasone, things like even olanzapine now. But there are patients for whom are just refractory to this, or where the side effects of their standard antiemetics are just too much. Ondansetron being the most common one is well known to cause headaches in some patients, or constipation, a common problem. And so it's been very useful for patients who we do know are going across the border to Oregon and getting them. So both anecdotally and by the data sets that are out there, we know it's helpful for that. I think there's one other, if we can advance the slide one more. I mentioned this, there's not, because the other purported use of THC or medical cannabis is to help gain weight or help for appetite. And that has not been borne out. I won't put any further slides in here, but I will tell you that there cannabis has been looked at in 8 different symptoms that also include depression, anxiety, and other areas. And really, to summarize, it really is only been shown to be effective for pain as an adjunctive and for an antiemetic. and 6 other areas, and one of them I put up here, it's not. So it's just not. We can go to the next. Yeah, and so I think this is a source that's probably more familiar to, again, and I don't routinely read the proceedings of the National Academy of Sciences, Engineering and Medicine, but did so simply because there's not a lot of data. But this is the one study I could find from 2015 that was the most systematic review of cannabinoids in general, so not specific to cancer. So it's a systematic review and meta-analysis. And you can just see there that there's moderate quality evidence to support its use for chronic pain, which is the interest that we have as oncologists, and low quality evidence associated with improvements in nausea and vomiting. And that's fair. It's not that there's no evidence, but I think we all know as practicing physicians that unfortunately there's a lot of areas in which we practice that truthfully the evidence is low quality, meaning there's an absence of randomized phase 3 double-blind controlled clinical trials, which is what most of us would consider the gold standard. So we're mostly talking about single institution studies, non-randomized studies, retrospective studies. And as you've heard from Dr. Randall pointed out that the cannabinoids were associated with increased risk of short-term AEs, of course. I mean, I'm not going to say that these things are not harmful. I'm simply here as an oncologist to say they're much less harmful than the opioids that we routinely need to prescribe for pain, and for some of the antiemetics that we prescribe for nausea. If we can go to the next, I'm going to shift over now just to show some opinion study. And again, this is not science here, but this is, I mean, I'm not sure to what degree, IMA is a representative body for us as physicians. You speak for the physicians of Idaho. And here I'm just going to give you some survey data. ASCO is the American Society of Clinical Oncology. This was a Harris poll that was done in 2019. If we go to the next. And this just to be clear, this was a study not done just to talk about medical marijuana, but was really a wide-ranging study to ask patients about their views on cancer, about end-of-life care, e-cigarette use, a whole host of things, inclusive of medical marijuana. So if we go to the next. So in this, I simply put this slide up just to show that I think on the top line, that again, for whatever it's worth, that most people support the use of medical marijuana for cancer patients, and a little less so for any medical reason, but that cancer patients are a special population. And then if we go to the next slide, I think this is, yeah, and I put this up, perhaps this was a residual from what I had presented to the Idaho State Legislature, simply to demonstrate that it's one of the few topics on which there actually is support for this across the aisle. And as you may imagine that, there's a little bit more Democratic support. 87% of people who identify as Democratic support medical marijuana use, but that a full 81% of Republicans, more reflective of our state, still support the use of medical marijuana. And then I think there may be one last slide. Yeah, this is really just something, again, limited data, but really it was an abstract from ASCO, so our national society, done from a study at University of Colorado, looking at the opinions of other oncologists, because again, I'm just one oncologist, just showing that, again, certainly not 100%, but that close to 3/4 of surveyed oncologists identify that medical marijuana provides benefits for cancer patients in our observations taking care of them. And interestingly, only half are comfortable recommending it, so that there's a true reflection of ambivalence. And I think if you had asked me to come on 3 or 4 years ago, I probably would not. I probably would have just kept mum, to be honest, and held my opinion to myself, thinking, I think the hardest part for me is that there's not a lot of high quality evidence. And the reason that after several years for our legislature asking me to testify on behalf of this, I had abstained. But that there's just too much accumulated experience on my part and my partner's part for the patients who have shown benefit in terms of taking care of their pain and taking care of nausea. And I'll admit and fully own up to just to a little bit of pragmatic support for this, in the fact that whether we agree with this or not, it absolutely is happening. I know some of you may not find that a strong argument or maybe even a counter argument, but a good portion of our patients are just doing it on their own. And it is frustrating that it's even more opaque than Dr. Randall had described, in the sense of being an Idaho provider and having patients just go across to Oregon and getting who knows what. But patients are using it. So again, that's my summary of some pretty high level data to support its benefits in patients with cancer and suffering from cancer, some survey data. And then just my, and my personal opinion based on my experience taking care of patients with cancer, knowing that this is a drug that does have side effects. Everything does. And remember that you're talking to someone who prescribes, chemotherapy. Really, again, fully studied FDA-approved drugs that can kill people, and that we do cause significant morbidity from our chemotherapy and other therapies. We cause significant comorbidity from the high reliance on opiate use, and do it only unhappily. At least in terms of the opiate piece, many patients have been able to get themselves off, or at least wean the degree to which they're relying on opiates for the pain piece. And we've just seen that over and over again. It just came to the point that even though there's not rigorous studies for it, it just became undeniable in my experience and my partner's experience. So that's why I present this to you, and happy to stand for any questions.
Thank you very much, Dan.
Very good. Thank you, Dr. Randall, and in absence, Dr. Zuckerman. Now we'll open it up to questions, and Susie will mediate questions or comments.
Great. Thank you, Dr. Williams. And there's already a few questions in the chat, so we will get to those. But if you have other questions, please message them to me. We'll get to as many as we can. If there are questions we can't get to, Dr. Randall has been wonderful about working with us to follow up on those, and we will make sure that we respond and get folks the answers that they're looking for. So the first question that was posted was asking Dr. Randall to comment on the cannabis hyperemesis. Is it related to dosing or contaminants? Are there risk factors for development?
I don't think we actually really know. We have endocannabinoid receptors in our GI system. It seems like it is probably related to dosing. The more you use, the higher you use, it seems more likely that you're going to get it. There has been some thought that some of the processes of processing the THC and the tinctures, there may be some colchicine. So it's a thought that maybe colchicine toxicity. It is also pretty much unknown, but we literally see this 2 to 3 times a day. So we don't really know why it happens. They don't respond to the traditional antiemetics. We've been using Haldol, so the antipsychotics, to treat the hyperemesis. It's very difficult to treat, and sometimes you can see electrolyte abnormalities that put them in the ICU.
Okay, thank you. The next one is, can you please touch on the fact that even though CBD that is used for medicinal purposes, they have all been found to be pure, that all of them have THC in them?
Right, that's part of the issue that we bring up when we talk about safety with products. And you'll see these advertised as pure CBD. But even if you look at hemp, which is supposed to be THC, there is new research out that shows even hemp, which is supposed to have less than 0.03% THC in the plant itself. But there's now been a way to develop something that's called THC-0 or O. And that is, as been touted by the industry, to be 3 times more potent than THC. But the current CBD preparations, even if you look, I see preparations in stores, they all have THC. And there have been numerous studies about when you look at like the amount of THC when you analyze the product content is widely variable to a significant amount or none. If it's made with hemp seed oil, hemp seeds are inert. So if you grind up a hemp seed and you put it in a product and call it hemp seed oil, there will be no product. So you might as well get Crisco for your treatment regimen. But if you look at CBD, it has a widely variable concentration of products. And it's also, if you look on the literature, lots of contaminants. So I think that's the issue with CBD. It does all say pure. We've asked it again and again and again for the FDA to make them put warning labels on the containers saying that it actually doesn't. There's been some lawsuits for truck drivers who use CBD thinking that it doesn't have THC, and then find out in their CDOT physical that they don't pass because they test positive. And one funny story was that our hospital was sending people for employee wellness to a massage person who was using CBD cream that also had THC. And I'm like, please, I told the CMO, please don't do your drug screens on most of your employees that went there because they're probably positive. So that's with CBD. It's being cranked out on numerous companies, and it has exceptionally little oversight.
Very good. Can you please speak to the paradoxical reaction of hypermedia? What's the best way to convey this to patients?
Oh, I'm not sure by hypermedia. We are being flooded, and the interesting thing is that the industry has lots and lots and lots of money because they tend to make stand to make a lot of money by selling their products. They have lots of lobbyists. In fact, I think in DC there are more cannabis industry lobbyists and pharmaceutical industry lobbyists at this point. They have a lot of money. Meanwhile, on the other side, I don't get paid for any of what I do. So the best way to, it's very difficult. It's very, very difficult to counter this, but you can show what I do for my patients is I'll print articles. I had a young man who they call it green out, took a lot of medicine and had a seizure. And it's well known in the industry this causes green out. So his family, of course, brought him in. They were concerned he had new onset seizures. And I said, well, cannabis can cause seizures. And they laughed at me like I was an idiot because, everybody knows it treats seizures. And I just gave them the article and I let that stop. When people have cannabis hyperemesis, I've only had one patient and all the people I've seen who go, yeah, maybe I should probably stop this. Only one. And the reason is that people find it very alarming to say that the drug they love is causing the illness that they have. And they don't see it as a problem with the drug. So what I do in their discharge papers is put articles in there for them because ultimately maybe they'll read them, but it's very hard and it's super hard to combat the literature and the hypermedia. And you have Leafly putting out circles of health with literally, I don't think there's anything that they say it doesn't treat. So it's very hard. All you can do is present the literature. And then again, the bottom line is that we're our custodians of health for our patients, and we have to give them the appropriate information.
Thank you. What forms of THC are recommended for cancer patients?
Well, we have Marinol. And most of the time, I think in the past, it's been recommended for appetite. And Marinol is a prescriptive form that you can for appetite stimulation. And I think that's one of the FDA indications. And it's an FDA preparation. And part of, if you look at what preparations are being recommended, part of the issue is that you could get a cookie today and a cookie tomorrow, and they'll have different concentrations of THC and CBD if they weren't made for the same preparation. So that's part of the issue with saying it's a medication for cancer patients. What people have been doing is telling cancer patients to go get cookies to control the nausea. And the side effects from that. We have lots of studies on pain control and looking at pain control with cannabis. And it actually shows, there's several studies recently that show people who use chronic cannabis actually have poorer pain control than people who don't. So I don't know that that's an issue. And that's the purposes. I know that it's being used for cancer. I think if I were to recommend it for anybody with cancer, I would recommend very low dose, and I would recommend an edible because smoking leads to lung damage, potential inhalation of fungus and heavy metal toxicity. If you used a low dose, I think it would probably be okay. I don't think that they would get, if using low dose, problems with hyperemesis, although to be honest, looking back at the last 8 years of legalization, you can't predict who's going to get hyperemesis.
Thank you. And I think you started to touch on this with respect to our next question, but any other differences you want to share between Marinol versus cannabis, any difference in safety, side effects, health effects, etc.?
Well, I think that if you look at it, Marinol it's a synthetic, so it's going to have less contaminants. It's going to be the same medication every time you open the bottle. One of the things that we talked about when, and it's not likely to be diverted. And so when we had the conversation with the board several months ago, you know, Dr. Zuckerman recommended that for his patients and said, well, you know, there is a side effect profile, but there's also a side effect profile with chemotherapy. And the difference between like cannabis and THC and chemotherapy is that each time you spike a bottle of chemotherapy, you are likely to get the same product. It goes through FDA. It has a lot of like quality checks along the way, where you don't have that currently, especially where we are in Colorado. You don't currently have that with THC products. So Marinol would be the same. At least it's got FDA approval. It's going to be the same product every time you use it. And it likely probably wouldn't have contaminants, or it would be recalled, whereas opposed to THC, where we have high contaminants, it may or may not be recalled. And the other thing with THC is that as opposed to chemotherapy with regards to the harms, is that, remember, THC is likely to be diverted. Diverted to kids, diverted to other family members. We had a recent study that showed most of the high school kids, or a good portion of them, probably about 35%, are getting their THC products from someone who bought it with a medical card.
Great. Okay, we just had one more question come in. Can you touch on other physician and patient responses to your opinions in Colorado?
I'm not sure what you mean. Most of the time, I don't say anything, because I actually had a patient when he had CHS, who was on his 7th visit in 7 days for vomiting. He'd had probably 30 visits in the last 6 months to the ER. It seems like it's cyclical. And once again, I suggested to him that it could be the cannabis, and his dad, who was across the gurney from me, stood up and yelled, "It's not the pot," and took a swing at me. So very seldom do I actually do that. I try to keep my patient encounters not political. Like I said, most of the people do not want to hear that this is the medicine they love is harmful. What I do see is a lot of people who come with their children who are acutely psychotic from using, we haven't really touched on that, but it's damaging our kids beyond belief. I am an advisory board on parents opposed to pot, because primarily of the acute psychosis I've seen with kids. We don't have enough addiction treatment. We don't have enough psychiatric services to provide for these kids. And so that's the only place where I'll be more than a little bit more than apolitical, I guess. So I don't really interact with my patients with regards. I'll make a suggestion, but if they want to hear it, they'll ask me.
Thank you. We had a couple more questions come in.
Mhm.
Would you say the risk to patients using cannabis recreationally is more, less, or about the same as alcohol?
Oh, more, way, way, way more. It takes away your judgment system, and the younger you use, the worse it is. I used to think alcohol was bad, but now it's like it's cannabis, and it's like, and I think the issue is that we kind of all now recognize, well, we educated the people and they know cigarette smoking is harmful, right? But then we saw vaping and we saw smoking pot come back, and they were trying to change the laws in Colorado so you can't smoke cigarettes in public, but you could smoke cannabis in public. And so the public sees it as a really benign product when it's actually a very potent psychoactive drug. And so they tend to drive with it. They tend to use it and try to do other things with it. We have a lot of side effects profiles, and we talked about those. So I would say it is definitely more, at least in Colorado here, there are way more symptoms associated with cannabis than alcohol at this point.
Okay, we have two more questions, and they're both related to heavy metals. So are there general differences in heavy metal contamination between edibles versus smoked cannabis?
Well, smoked cannabis, I don't know that there's been studies, and that's a good question. I don't know that there's been studies. First of all, I wouldn't recommend smoking for anybody. But to be honest, I think if you looked back and extracted the heavy metals in a smoke product, will be far less than a concentrated product, because the tinctures And the edibles are all made from THC concentrates, which when you take it, you concentrate the THC, but you're also concentrating the other products as well. You're leaching them out with a solvent. So I think that it'd probably be better in an edible, probably less.
Okay, and we have time for just this last question, which says, I assume that the heavy metal, fungal, and bacterial contamination would be less if grown indoors in a controlled setting with hydroponics. Do you think that is true and would be a way to control these potential contaminants?
So that's an issue with the industry. And the problem is it's probably actually more grown indoor and controlled with hydroponics, because what you're doing is forcing the plant to go through its life cycle faster. So what they're using is lights, grow lights, which generate heat, which generates the need for like air conditioning and wind tunneling. And even hydroponics, you're adding fertilizers, you're adding other additives to make it grow. So, and then you're growing it in a very high, very humid condition. So then, I mean, we have rules and regulations, and each state with regards to cannabis has its own regulations. And here in Colorado, we do have some regulations, but you know, they're not always necessarily upfront about what they're using. And so we're finding that they'll use antifungals that are toxic on plants, and especially if they're grown in a not legal manner, then we see it. And it's actually probably worse indoors because of the high humidity and the chemicals used associated with it.
Great. Thank you. That's all the time we have for questions, but we will take any further questions offline and follow up with Dr. Randall and get back to you all who have those questions. But Dr. Randall, thanks so much for your time and for what you do. It's been very, very informative, and I know our board has been very appreciative of your efforts to get us educated.
Yeah, you're welcome. I try to do this because I think it's very important for us as physicians to know about this. And I'm surprised even at the number of my colleagues here who don't. I'm available for questions, just forward them to me through the board. I'm happy to provide like resources, literature. I know people across the country who are experts in their own field at this point as well. So I can provide any resources if you have questions beyond what I can answer.
Wonderful. Much appreciated. Thank you to Dr. Randall.
You're welcome. Thanks for